Happy to be here today with Andrew Moshfeghi of the University of Southern California Roski Eye Institute, where he is director of the Vitreoretinal Fellowship and medical director. He is the vice chair for clinical research as well. And we're going to talk today about his exciting presentation at the Angiogenesis 2021 virtual meeting on the use of a TKI agent in an hydrogel implant for the treatment of choroidal neovascularization. So, Andrew, welcome.
Thank you.
So can you tell us a little bit about the background for the research that you reported on?
Sure. So what I presented at the angiogenesis meeting was the interim analysis of the phase 1 study, which is currently underway in Australia, evaluating the use of axitinib combined with a proprietary hydrogel, both delivered together intravitreally to try to get a long-lasting, durable benefit for patients with neovascular AMD. And the reason why we think this may be helpful is that this is a very potent tyrosine kinase inhibitor, which even at very small concentrations has a observed biologic effect. And we hope that that effect is long lasting in these patients. This was sort of the first in human data that were being evaluated.
So it was a dose escalation trial, and you found some very interesting things at the mid and high doses.
True. So at the lowest dose, which is the 200 microgram dose, we didn't see very predictable and consistent biologic effect. However, at the 400 microgram and 600 microgram levels, we saw more significant detergescence of the macula, which in some patients were also associated with changes in visual acuity for the better.
And the durability lasted up to more than 6 months in 1 or 2 eyes, correct?
That's true. Now, there's two kinds of durability that one can look at. There is the visible dissipation of the drug over time, and it sort of has a bright white appearance, against the fundus background. And so it is observable on wide field fundus imaging, and it's also observable using binocular indirect ophthalmoscopy. So you can see the dissipation of the implant drug complex over time, and that can last 6 to 9 plus months and beyond when you're visibly watching it dissipate. Now, unfortunately, the cohort of patients that we have the longest follow-up on is also the lowest dosed cohort, the 200 microgram cohort. So we have less ability to see if that visible dissipation of the drug translates into a similar effect on a biologic effect over time. So we'll have to get longer follow-up in these middle dose and the high dose cohorts in order to see the true biological durability of this drug over time. And we're just not there yet. For example, cohort 3A, which is the 600 microgram cohort, highest dose cohort, and that's without any anti-VEGF. That cohort has just recently been nearly completed, and so it's going to be another 6 to 9 plus months from this point in order for us to draw strong conclusions about the mean durability in terms of biological effect for that cohort of patients.
Mm-hmm.
But it's certainly promising from this point.
Well, there's at least one eye with OCTs that showed that there was initial subretinal fluid which dried by 1 month, and then by 6 months or more was still anatomically normal on OCT.
Correct. Yeah, we show a patient in our presentation who is from cohort 3A, the one I just referenced, subject 1. This was a treatment naive subject who had, nearly 500 microns of central retinal thickness, and almost 20/80 vision, and no prior treatment, as I mentioned, who by month 2 had literally no fluid in the fovea and 236 microns of central retinal thickness, and visual acuity improving to 20/30-ish by that point. And as you point out, required no additional ad hoc rescue treatments out to month 6, and was still free of fluid. So that's certainly the type of patient we wish to see more of. And hopefully we'll have that experience as time goes by.
Hmm. Hmm. Well, TKIs have been of great interest in the treatment of neovascularization. The trick has been to get them into the eye for a sustained period of time, because unlike an antibody, which has a relatively long half-life in the eye, the half-life of the TKIs by themselves in the eye is relatively short.
Yep.
But in contrast to the proteins, you can actually hopefully put the TKIs into things like hydrogels and get them to be sustained. One question: do TKIs have a enough early drying effect on the neovascular complex or not? Do we know
Well,
that?
it's an interesting question. So traditionally, we felt that they, as a class of drugs, just simply did not have enough potency early on, and enough early onset of action to dry the macula up like we've become accustomed with a conventional pan-VEGF blocker. That being said, that same patient that we referenced earlier as a sort of an exemplar patient, this is the highest dose cohort, and it's possible that you just need higher doses present in a tolerable fashion, possibly, to have an early onset of action. We won't know that until we have more higher dose patients followed over time to see if that's truly the case, or whether this is just sort of a one-off type of an example. But I will say this: it may not necessarily be the case that TKIs just simply aren't capable of drying maculas up on their own in the beginning in wet macular degeneration. It might very well be the case that there are instances in which that can occur, and we just need to explore that a little bit further. But certainly we saw some exciting examples where on its own there does appear to be an early effect.
So there is also apparent good systemic safety, because the amount of drug that gets into the systemic circulation is extremely low. Isn't that correct?
That's true, and even when it does hit the systemic circulation, the systemic half-life is quite low, and we saw that the plasma concentrations were below the lower limit of detection in all the tested samples at all the tested time points. So that was reassuring.
And the TKI in question is more potent than other TKIs that have been considered in the past?
Yeah, so when you look at the various TKIs that have been evaluated for different aspects of medicinal use, axitinib, which is the TKI that we're using here, has one of the lowest IC50s, really at the nanomolar concentration, in which we're still seeing this effect. So when you look at comparator TKIs like sunitinib, for example, uh, it's 2 orders of magnitude higher IC50 than that of axitinib, which is a similar uh, reference comparator to the other uh, tested TKIs that are being looked at for ophthalmology.
And the method of delivery is via a syringe?
Method of delivery with this study was via 27 gauge syringe. It's an injection, an intravitreal injection. And moving forward, we may use a single implant injector, which would use a 25 gauge needle via intravitreal injection, as opposed to using multiple 200 microgram injections. We'd use just a single injection, but that's in development.
So what's next on the agenda for this product?
So we need to continue finishing enrollment in the cohort 3B of this study, which is the 400 microgram intermediate dose of OTX TKI along with a single baseline aflibercept injection. And once that enrollment is complete in the coming weeks and months, then we'll be able to follow this study out to its completion, get the long-term follow-up, and see how the study did down in Australia. We also have an exploratory IND with the FDA to allow us to proceed here stateside with a similar sort of phase 1A, phase 1A study to allow us to gain some additional insights with the new injector, as well as the single dose injection platform.
So Andrew, thanks so much for participating in retina synthesis, and we look forward to hearing more about this very promising therapeutic approach.
Thank you for the invitation, and I enjoy the platform, seeing these interviews very much. Appreciate the opportunity.
Okay, thank you.